Hi, welcome to NEET PG Core Revision Series in Pharmacology, where I, Dr. Deepika Tikku, am going to revise all the important topics which are very important for your upcoming NEET PG examination. So let's start with the autonomic nervous system today. So autonomic nervous system, or the ANS in short, it is divided, we know, into two parts. One is the parasympathetic nervous system and the other is the sympathetic nervous system. Now, the neurotransmitter in the parasympathetic nervous system is acetylcholine, while in the parasympathetic nervous system, mostly it is noradrenaline with a few exceptions. So, we should always know the exceptions. So, exceptions in sweat glands and adrenals here, we have acetylcholine in the sweat glands especially, and adrenals, the ganglion actually relays on the adrenal gland. Then renal blood vessels, we have dopamine. The receptors for parasympathetic system is nicotinic and muscarinic. So, nicotine NN in the autonomic ganglion and NM on the neuromuscular junction. Muscarinic we have M1 mainly, M2 and M3. So, these three are the main receptors, M1, M2 and M3. They are M4, M5 as such till 7 at least, but we are usually concerned with these three are the most important. Then sympathetic nervous system, alpha 1, alpha 2 and beta 1, beta 2, beta 3. So, these are the important receptors. Moving on to the cholinergic transmission here. So, in the cholinergic transmission, please remember the rate limiting step here is the uptake of the choline, right? And the choline uptake by the presynaptic neuron, and it is blocked by a drug called as hemicolinium. Okay, so choline and colinium, remember that ways. Then once the acetylcholine is formed inside, it needs to get stored in the storage vesicle here, right? So the drug which can inhibit the storage of acetylcholine in the storage vesicle is called as vesamicol. Vesa means vesicle, so remember like that, vesamicol inhibits the storage into the vesicle. Third and very important drug, which is your botulinum toxin, it works by inhibiting the release of the acetylcholine, right? So, it is asked in the exam the mechanism by which the botulinum toxin works, and that is by inhibiting the release of the acetylcholine. So, here we have drugs like prabotulinum toxin A, which inhibits the release and it is used for glabellar lines. Botulinum toxin A is used for treatment of strabismus, blepharospasm, and onabotulinum toxin, if you remember, it is used in case of prophylaxis of severe cases of migraine. Onabotulinum toxin. Okay. So, moving on to the effects of these parasympathetic versus the parasympathetolytic, or the mainly cholinergic versus the anticholinergic mainly. So, what are the effects on different organ system? Let's do them one by one. The first organ system or first organ we are going to talk about is the eye. Very important is the eye. So, in the eye, let's take in the pupil. So, there are two types of muscles here, and one we have these are the circular muscles, and we have the radial muscles. Okay. So, when circular muscles contract, they are going to cause meiosis. When the radial muscles contract, they are going to cause mydriasis. On the radial muscles, the receptors we have are alpha 1, and on the circular muscles, the receptor we have is M3. So, contraction of the M3 receptors is going to cause active meiosis or stimulation of the M3 receptors rather, and alpha 1 stimulation is going to cause the mydriasis, but active mydriasis. But if you block M3 receptors, then there is going to be unopposed action of alpha 1, but that is called as passive mydriasis, right? And if you block alpha 1, there is unopposed action of M3, then that is called as passive meiosis, right? So, that is the difference between active and passive effects. So, use here, let's do the uses here. So, use in case of parasympathomimetic, we have a drug called as pilocarpine. Pilocarpine, which is the drug of choice for closed angle glaucoma. Closed angle glaucoma, right? Mydriasis, which is caused by parasympatholytic, it becomes a contraindication. So these drugs are contraindicated in glaucoma because mydriasis is not required. So uses where we have drugs like atropine, we have tropicamide, we have homatropine. So these drugs are used for fundus examination, for testing the refractory errors, right? And number 3, in case of various inflammatory conditions like uveitis, iridocyclitis, basically they break the adhesions. How do they break the adhesions? You actually, what you do, you alternate them with the meiotic. So there is meiosis, mydriasis. Meiosis, mydriasis leads to breakage of the adhesions. Moving on to the central nervous system, where the parasympathomimetic drugs, they are going to enhance the memory and cognition. So they are used in case of Alzheimer's disease. So drug of choice here, we have a drug donepezil, we have rivastigmine. So remember, rivastigmine is also available as a transdermal patch. And we have galantamine. Okay. Now, on the other hand, parasympatholytic effect leads to mild sedation and delirium. So drugs like scopolamine, it was initially used for narco analysis. So because in patients, when you treat like from criminals, when you want to extract the tooth from them, so when you give them this drug, they are sedated and slightly they have delirium. They can't lie actually. So it's like a lie detector test in them you use. Then respiratory system, M3 receptor is a predominant receptor here, and stimulation of this M3 receptors causes bronchoconstriction and enhancement of the secretions. So we don't have a use in this case. While on the other hand, the parasympatholytic effect is bronchodilation and reduced tracheobronchial secretion. So here we use them. So this is used in conditions like bronchial asthma and COPD. So COPD, the drug of choice, we have tiotropium. Then we have other drugs like ipratropium bromide and umeclidinium. This is the ultra long acting muscarinic antagonist, right? And this is the short acting muscarinic antagonist. And this is the ultra long acting muscarinic antagonist. Okay. Now, on the heart, M2 receptor, when it is stimulated, it leads to, you can say, depression of the heart. So there is decreased heart rate, conduction, force of contractions. Again, here we don't have a use for this part, but increase in heart rate and conduction can be put to use. And what is the use here? This can be used in case of bradycardia or AV block. Okay. And which is the drug of choice here? We have atropine. So atropine is used 1 milligrams. So that is the use here. On the GIT, there is M3 receptors present and it leads to contractions and increase in the gastric secretions. So initially we use a drug called as bethanacol for post-op ileus. But here we use it rarely now, but yes, it was used because in post-op ileus there is decrease in the contraction, so we can use these drugs. So to decrease the contraction or decrease the gastric secretions. So for decreasing the contraction, so we have the antispasmodic action. So you can use them as an antispasmodic. So antispasmodic action by a drug which is we mainly uses dicyclomine. So decrease the gastric secretions, we use drugs like pyrenzapine, tilenzapine for peptic ulcers. Then on the blood vessels, now M3 receptors, they cause vasodilatation by release of nitric oxide or EDRF, right? Otherwise, the predominant blood receptors in the blood vessels are the sympathetic, alpha and beta. But this, they whenever they are stimulated, or then they cause vasodilatation by NO. There is no active use as such, and this can be blocked by giving acetylcholine. Now moving on to another important organ, which is your bladder, and again they have M3 receptors, which is predominant here. So M3 receptors here, because they will cause bladder contraction. Bladder contraction. That is the important role here. So bethanacol, the more important use here of bethanacol is to use in post-op urinary retention. Post-op urinary retention, or in case of neurogenic bladder. While on the other hand, the parasympathetic effect would be relaxation. Bladder relaxation. So we have important drugs here. So we can remember 5 dots as a mnemonic. 5 dots. So we take the F of the 5 and the dots. So F here is flavoxate, darifenacin, oxybutinin, trospium, and tolterodine, solifenacin. So where do we use these drugs? So they can be used in case of overactive bladder. Overactive bladder or urinary incontinence, there they can be used. Right? Now, important things are, they ask you that most of these drugs, they can also lead to some memory deficits or dementia, because they can also block the M1 receptors in the brain. So which of these drugs are safer in that regard? So darifenacin, solifenacin, and this trospium. So they are safer in this regard. So they have less chances of dementia. So they are preferred. And overall, currently we prefer mirabegron for overactive bladder because it has less of these side effects. So otherwise, out of these, we prefer darifenacin, solifenacin, and trospium. All right. The next organ system that we have is the skeletal muscle, that is NM, neuromuscular junction. So contractions are definitely important because of the presence of NM receptors. So what is the use here? Let's say we have a drug called as neostigmine. So neostigmine is a acetylcholinesterase inhibitor, which leads to increase in the cholinergic level, acetylcholine levels, which can further act on the NM receptors to cause the contraction of the muscle. So where is it used? So neostigmine can be used in myasthenia gravis, but remember the drug of choice, actually we have pyridostigmine. Again the same class of drugs, but we don't use physostigmine because physostigmine is a tertiary compound. It crosses the blood-brain barrier and we can have side effects. We don't want the effects on the central nervous system, only the peripheral effects. So here we prefer the quaternary compound like neostigmine or the pyridostigmine. So it can be used in myasthenia gravis. It can be used in cobra bite, neurotoxic cobra bite. Then it can be used in for reversal of neuromuscular blocking agents. So in a surgery, we are using neuromuscular blockers. So to reverse the effects, we can use them in this case as well. right? So in these cases, basically, we always combine the drug with atropine. Why? Because all these effects are desired due to their action on the NM receptors. But when you increase the level of acetylcholine, they will also going to, because it's a non-selective drug, a non-selective parasympathetic neurotransmitter. So it is going to act on the muscarinic as well on the nicotinic receptors. But acting on the muscarinic receptors are going to bring a side effect which you do not want. So to prevent that, we initially first give atropine, which is going to block the muscarinic receptors, and then you give neostigmine, because then the only effect would be observed on the neuromuscular junction, right? Okay. So another drug here we have is edrophonium. Now, edrophonium is a very short acting drug. So, if you give this drug, we can use it for diagnosis. Wherever you are doubting, so it can be used for diagnosis of myasthenia gravis. So, if you give this drug, a little bit of the drug, there will be improvement in the patient. So, you know it is myasthenia gravis, and then you can start the treatment. But let's say there is worsening of the symptoms if you give edrophonium. That means it is a case of cholinergic crisis. So there is over treatment with cholinergic drugs, cholinergic crisis. So this, to diagnose the myasthenia gravis, this is called as the tensilon test. So what is the benefit to us? So if you know that myasthenia gravis is there, we'll add on the treatments, or if it is improvement in the case of that person, that means you need to increase the dose of the drug. But if there is worsening of the condition, if there is a weakening of the muscles is because of over treatment with the cholinergic drugs, then the thing is that you need to decrease the dose of these drugs. So that's how you can evaluate the patient. So this was for the contraction. Then parasympathetic effect is the drugs which are neuromuscular blocking agents like succinylcholine, matracurium, etc. They are going to cause relaxation. So they are used in case of surgeries, right? In surgery we use them along with the anesthetics. Then glands. Glands also have M3. So all the glands like salivary, lacrime, etc. So cholinergic system or parasympathetic system stimulation leads to increase in all these secretions. So we have drugs like pilocarpine and cevimeline. Cevimeline is a new drug, but both of them, they are used for treatment of dry eyes, or what we call that, a dry eyes and mouth. So dry eyes and mouth, it is called as xerostomia, where it is a part of a Sjogren syndrome. So there is dry eyes, dry mouth. So these drugs are going to enhance the secretion. Decrease secretion use is where it is used preoperative as a part of pre-anesthetic medication. So we are used drugs like glycopyrrolate. So glycopyrrolate is going to decrease the secretions. So this is going to prevent any cases of aspiration during the operation. So we prefer to use glycopyrrolate because it does not cross the blood-brain barrier. Instead, like in contrast to atropine crosses the blood-brain barrier, but glycopyrrolate, it does not cross the blood-brain barrier. Then in the autonomic ganglion, we have these parasympathetic system is going to stimulate, while the blockers, the ganglion blockers we have are trimethophan, hexamethonium and mecamylamine. So here trimethophan is used in cases of hypertensive emergencies, but not a very popular drug as such. So an important topic is organophosphate poisoning or OP poisoning. So what is organophosphate poisoning? See, the enzyme acetylcholinesterase. So we have this enzyme acetylcholinesterase, and this enzyme has two important sites. One is the anionic site and other is the esteratic site. So what usually happens? this acetylcholine, it binds to the anionic side with the help of the N positive. So this is the negative charge here. So this electrostatic attraction is there. And then it gets hydrolyzed by action on the esteratic side, right? So this happens in milliseconds. It gets metabolized. But what happens in cases of poisonings? So in case of poisoning like organophosphate poisoning, so these are acetylcholinesterase inhibitors, but they are irreversible inhibitors. So what this drug does is, or this poison does, organophosphate poisoning, the drug binds to the esteratic site. So here this is the organophosphate. It has bound to the esteratic site. So when it binds to the esteratic site, this hydrolysis of acetylcholine does not take place. So when this hydrolysis does not take place, that means acetylcholine gets on accumulating in the body, right? So increase in the acetylcholine levels are going to lead to exaggeration of all the parasympathetic stimulatory signs and symptoms. So you can remember them by the mnemonic, that is dumbbells. Right? So all these symptoms can be seen. So there's going to be diarrhea, increase all the secretions, urination, there's going to be meiosis, there is going to be bradycardia, there is going to be bronchospasm or bronchoconstriction, there is going to be emesis, there's going to be lacrimation, and there is going to be salivation. Right? So all these things are you're going to see in an exaggerated form. So typically meiosis, you want to suspect what poisoning is there. If there's increase in the secretions, it is organophosphate poisoning. If there is respiratory depression, you suspect the opioid poisoning, right? So this is because of the esteratic side. Now, what is going to drug of choice, how you treat it? Because acetylcholine is going to act on the muscarinic as well as the nicotinic receptors. So you want to, these are the life-threatening signs basically are because of the muscarinic activation, receptor stimulation. So you want to block the muscarinic receptors first. So therefore, your drug of choice here becomes atropine, which is an anti-muscarinic drug. So you give it by the IV route. 2 milligram by the IV route. You give it every 10 minutes till the signs of atropinization come. That means the atropine is slightly going to show its symptoms. The most common you can see is the mydriasis. The pupils will start dilating. So you know that atropine is going to show its effect. Then this is going to take care of the muscarinic symptoms. The most specific drug, we have the oximes like pralidoxime, right? So what are oximes going to do? Now oximes are going to bind to the anionic site. So let's say we take here the oxime, and oxime, it binds to the anionic site. So when the oxime, it binds to the anionic site, it is going to form a phosphorylate, this organophosphate, and it is going to pull it out from here and again free the enzyme. So this is important that it binds to the anionic site. But remember, this whole process needs to take place before the process of aging. What is aging? So this needs to be before aging. Otherwise, this is going to be ineffective. So aging, in aging, the organophosphate bond is going to become very, very strong, and this oxime is not able to remove it from the site. So it is very time dependent. So within the first few hours, if you get the patient, oximes are going to work. Otherwise, oximes are going to fail. So oximes used here, but remember one thing, there's another poisoning which can be seen with the carbamates. What is the difference between the carbamate poisoning and the OP poisoning? In the OP poisoning, the organophosphate was just attaching to the esteratic site, but carbamates, they bind to both the sides. So they bind to both sides. So you see here that oximes do not have a site to bind. So in this case, therefore, oximes are ineffective. So oximes are ineffective. So they are contraindicated in this case. Okay. So just like this, we have other antidotes which we should be very well aware of, because antidotes are very favorite. It's a favorite question in the NEET PG exams or the FMG or INI-CET. So everywhere they ask at least 1 or 2 antidotes. So let's do these antidotes, and we should be very thorough with these antidotes. Very scoring. So let's not miss these. So in organophosphate or carbamide, I told you that first drug of choice in both, it will be atropine. And then we can use the oximes, but not in carbamide poisoning. Remember. Datura, belladonna, atropine. So whether it is atropine poisoning, belladonna, datura, same thing. You give physostigmine, a tertiary compound, not a quaternary compound here. Digoxin, we have digibind or digifab. Beta blockers, glucagon. Benzodiazepines, flumazenil. Morphine, naloxone. Methanol or ethylene glycol poisoning, we have formipizole and we have ethanol. Tricyclic antidepressant and salicylate, so these are acidic drugs, so we need to give an alkaline agent here, sodium bicarbonate. Paracetamol, N-acetyl cysteine, here the culprit is napquine. Heparin, protamine sulfate. Warfarin, vitamin K. Apixaban, XA, 10A antagonist. Rivaroxaban, 10A antagonist. So we have Andixanet alpha. So again 10A, no 10A. So Andixanet alpha. Dabigatran, idarucizumab. Right? So dabigatran, idarucizumab. Cyanide poisoning, hydroxycobalamin. We can also use nitrite plus sodium thiosulfate. Methotrexate, folinic acid, or citrovorum factor, or leucovorin. So these are the name of the same compound. So these are the drugs which we can use for the various poisonings. Alright, so important topic is myasthenia gravis, which is asked. So what is myasthenia gravis? Myasthenia gravis occurs when the NM receptors, so these are the NM receptors which are present on the neuromuscular junction. So autoantibodies, they are formed, so they destroy the nicotinic receptors, NM receptors. Then very few receptors will be left for acetylcholine to produce the effect, right? So what can be done here is, the best thing is the whatever, because you know acetylcholine gets metabolized also very fast. So whatever time the acetylcholine is there, at least that time can be increased, so that whatever left receptors we have, acetylcholine gets time to act on those receptors. So we need to increase the stay of acetylcholine here or decrease its metabolism. So therefore, we use drugs which increase the levels of acetylcholine or make it stay there for a long period of time. But there are certain drugs which should not be given in such cases, which already there is a weakness of this skeletal muscle. So other drugs which are also causing the weakness of the skeletal muscles, we will not give these drugs. So for example, neuromuscular blockers, right? So they should not be given in case of myasthenia gravis. Aminoglycosides. So aminoglycosides are the protein synthesis inhibitor, but it inhibits the calcium. It inhibits the calcium entry into the neuron. So here calcium entry is important because then only the acetylcholine is going to go out. But when this calcium entry is blocked by aminoglycoside, the acetylcholine doesn't come out, or it is not released from the presynaptic neuron. So therefore, it is not to be given here. Then we have drugs like calcium channel blockers. Calcium channel blockers, or we have morphine. What does morphine do? Morphine causes respiratory depression. So it can, then in such cases already the muscles are not working properly, so it can aggravate the condition. Then magnesium. Magnesium works opposite to that of calcium. It causes relaxation. It is going to also inhibit the release of acetylcholine. So all these drugs should be contraindicated in case of myasthenia gravis. So I told you the tensilon test, it is done with edrophonium. So we use edrophonium 2 milligram IV route and we diagnose whether this patient has myasthenia or not. Why or how can we diagnose? Because the patient, as soon as you give this drug, will start showing improvement in it. So once the patient is diagnosed, then you move on to the treatment. And the treatment here we have pyridostigmine. That is the drug of choice along with atropine. Then we have corticosteroids like prednisolone. Then we can use immunosuppressants because they are autoantibodies, so we use immunosuppressants like azathioprine and cyclosporin, right? So we can also do thymectomy, we can do plasmapheresis, etc. But these are the drugs that you can use. Then drugs for smoking cessation. So to quit smoking, we have drugs which can be used, and you can remember it by NVB, mnemonic, nicotine very bad, right? So nicotine replacement therapy. So it can be in form of various dosage forms, like we can give patches, we can give lozenges, we can give gums, chewing gums, and we have nasal sprays. And this is a very, very fast method. Then we have varenicline, which is a partial agonist at the nicotinic alpha-4 beta-2 receptors. So what it does, it just maintains a very moderate level of nicotine. The high is not there. So it maintains moderate nicotine levels, right? And also because of this, there is moderate level of dopamine. So when this is stimulated, it's a partial agonist. So there is moderate dopaminergic or the reward system which is activated. So not very high as compared to when the cigarette is smoked. So this is one of the most effective drugs. Most effective. Then bupropion, it is actually an antidepressant drug. Antidepressant drug. It is given as a sustained release formulation and is contraindicated in case of seizures. Now, another important topic here is atropine poisoning, which is asked. So, in atropine poisoning, what you will see, all the opposite effects to the dumbbells basically, but what are the significant things that you should note in this is that patient will have mydriasis, patient will have dryness of mouth, there will be tachycardia, there will be hyperthermia, right? So you see these things in the exam question, you immediately come to know that it is atropine poisoning. And what is the drug of choice? We did the antidote for atropine poisoning, that is physostigmine. That is the drug of choice. Remember, because of this problem of hyperthermia, this atropine is contraindicated in children. Okay, this is because of this, it is contraindicated in children, because in children won't be able to make out, they won't be able to complain. So they'll high fever. And why is this hypothermia occurring actually? Because it causes decrease in the sweating. So it is contraindicated in children. But in children, you will see that we use atropine in the eye for children because they are very high tone, so they need cycloplegia. So atropine is used in children. But what is the dosage form in children which is preferred? We use atropine in the ointment form. We don't use the drops because the drops would go through the nasolacrimal duct and they will enter into the systemic circulation and they can have this side effect. So therefore, atropine ointment, this is preferred in children. Preferred in children. Okay. So these are the important points from the parasympathetic nervous system.